we have to. You guys use ion tow a lot at? Oh yeah. Okay. Interesting. Handful of years ago, your site was the #1 site in the state for ion tow. That explains a lot. So I like iontophoresis because we can deliver medication through the skin, and there's a lot of good reasons why we'd want to do that. One, we get to avoid needles. So for our patients who have intense fear of needles, it's a great thing. And I was talking with a pain doc. I shadowed him for a day in my schooling. And he's doing injections all day long. He's prescribing pain patches all day long. He's using different topical creams all day long. And I asked him, I didn't see him talk about any pain medications, oral medications. And I asked him, like, do you ever do this stuff? And he goes, why would I, if a patient's having focal pain, it hurts here, why would I give a medication that works everywhere when I have opportunities to just do here? So it was great to listen to him. Got to be careful because he's a pain doc that does injections all day long. So of course, what he thinks is great, right? Never ask a barber if you need a haircut. Yeah, sure, sit down. But I do think for some people it's really, really valuable. And I do think there's definitely times when we are talking about oral medications that work systemically that we don't really need to. So what we're going to use for iontophoresis is electropulsive forces to drive medications into the body. Great benefit is it avoids the liver. The liver will break down the medications. Also, repeated medications can damage the liver, so that's important, and kidneys as well. So, man, if we can avoid that, that's nice, especially if we're going to need long-term use of this stuff. And again, we're treating the area focally, really local area instead of everywhere. Now, your patient needs to have an explanation of what's going on. Why are we doing this? And usually a magnet works. So the medication has a charge to it. When I hook up the electricity, that's got the same charge and it's going to repel away just like two ends of a magnet. You played with magnets a lot as a kid, right? Right after you licked the batteries. Yeah. So the additional precautions, all of our regular E-stim precautions exist. The additional ones that we have to ask about is allergy to the medications we're going to use. An additional precaution is thin skins and areas over bony prominences we want to be careful with. With iontophoresis, it's a direct current. So all of the currents we've been using before have been alternating to some degree, where there's going to be moments of positive followed by moments of negative. With iontophoresis, it's direct. So that means it's always going to be negative or always going to be positive. The danger of that is we're going to build up the opposite ions underneath the skin, and that can cause a chemical burn. So we want to avoid areas of thin skins, and especially if our patient's thin skin already, then we've got to really be careful with that. Yep.
So, before we were doing stuff about edema, was that always negative or positive charges? So I know you said like it's gonna go towards it or away from it. Are they always simply one or the other?
Yeah, I think we're going to talk about edema later today as well. Edema is always going to have a net negative charge. So we would want, what charge electrode would we want to place near the edema then, if it's negatively charged?
Negative.
Negative, because
It's gonna go.
all right, if we have a bunch of swelling that's negative, and we place an electrode on it, if we have a negative electrode, are these ions going to be attracted to or driven away from? Away, right? Versus if it was positive, now we're actually drawing more towards the area. We're going to be attracting more, right? So opposites attract. Anyway, we'll talk about that a little bit later too. So skin, just quickly, the skin, largest organ of the body, two main layers, epidermis and dermis. Epidermis is avascular, and then dermis is the vascular section. Outer layer of the skin, stratum corneum, high resistance to the flow of electricity, low water content. It's negatively charged. With application of our current, it's going to change the local ion concentration, and we're also going to reduce impedance. We can also heat or hydrate the skin. That will reduce impedance. So one of the things we're going to want to do with iontophoresis, we've talked about it a lot, but we really want to make sure we have improved conduction through the skin, because we're trying to deliver medication through the skin. So if you know your patient has high resistance, heating is going to be the first step. And one of the things we're always going to want to do is clean the skin. Before it was, okay, if this doesn't work, go clean the skin and try again. Our first step here is going to clean the skin where the electrodes are. So we're going to be driving through the stratum corneum. We have transepidermal and transeppendygeal medication delivery. Transepidermal is intracellular. Transepidendial is to the skin appendages. That's where the hair follicles or sweat ducts are. There are some drugs that we use passively. We don't need additional current to deliver medications. Nicotine patches, motion sickness passes, some pain patches, non-steroidal anti-inflammatory patches. Throw those on and you don't need to do anything with it, right? It's just on, it'll just slowly deliver the medication. But for us, we're going to want to add current to drive the medication into the skin. The electrode is going to be the same polarity as the charge of the drug. So we have a few different drugs choices for us, and we want to make sure that we know what the charge is, that we know which electrode to use. It is direct current E-stim. So it's either always going to be positive or always going to be negative. So there is a risk of those chemical burns now. So we do have to be careful with our patients. Pads should be placed a minimum of 1 inch apart. Most of the manuals, we have a handful of different iontophoresis delivering machines here. Most of the manuals say 4 to 6 inches apart. So a minimum of 1 inch apart for the pads, 4 to 6 inches is ideal. Here's the most common medications that we have and the purposes for it. So I don't see it used often, but acetic acid, negative charge. Well, these are good for calcium deposits. What are calcium deposits? When are we worried about those? Gout is uric acid deposits. What'd you say? Heel spurs, perfect example. Bone spurs in general. The two most problematic occur at the calcaneus, plantar fascia, and then at the acromion, if there's a little bone spur there. How much room do we have underneath the acromion? Not a lot. So if we have just a small calcium deposit bone spur, that could be it. It's there for us. I've never seen it actually be beneficial clinically, but hey, it's there for us. Maybe the patient's not a surgical candidate. We got to try something. Calcium, positive charge, good for muscle spasms. And if we go back to how the action potential of how muscles contract, that makes sense. Dexamethasone, probably one of the top two. The dexamethasone and lidocaine are probably the top two medications that I've seen used for iontophoresis. Negative charge for dex, good for tendonitis and bursitis. Lidocaine for pain, negative charges for both of those, and chlorine, negative charge for scar tissue. So of all the medications, obviously there's more medications that we could use. These are the most common ones with some of the most common reasons for using it. What's one quick study thing that you can do if you study? I can study this in 2 seconds and get there's only one positive. Yeah. So if on an exam, if it says, is this positive or negative, you don't even have to study. You just guess negative and you'll have a 4/5 chance, an 80% chance to say, well, now I've got to put the calcium question on there. So, at least you just need to know one. So, I'll look at the exam and try to give you a better study guide. I feel like I'm more interested in the purpose of it, but anyway. Yep. Yep, we're a team. So definitely, if there's a reason I think we need to use this, and yes, I would call the doc and they would prescribe it. Some people walk in with this already. Some people get prescribed physical therapy and the doc just writes it automatically. It's just an automatic thing that happens. Nope. Yeah. Yep. Yeah, teamwork approach. Sometimes the patients get prescribed it and we don't need it, and we'll just say, hey doc, we're not going to do this. We're going to do this without. And most of the time they trust us because we know what we're doing too. And we want the best outcomes for the patient too. So yeah.
Is this an idea, I guess, to like an ultrasound guided implant injection? Because I work I'm like an admin for like that type of department. And
Yeah.
like I have to come and get my injection, and it's always a lidocaine, the whatever into like that's an actual injection, but they use an ultrasound to facilitate it.
All right. So two different little bit, yes. There was ultrasound delivered medication. You guys remember what that was called? Yeah. That's a perfect, yes. Phonophoresis, right? So we could use our therapeutic ultrasound to deliver medication called phonophoresis. You're talking about ultrasound guided injections. So that's imaging ultrasound. So that's where, if we want to be sure we're getting to specific levels in between the vertebrae, or I want to make sure I get into the joint, we're going to use imaging to make sure, okay, I can see the anatomy on the screen, I can see the needle into the screen, and it's right there. That's not us. Yeah. Yep. Yes, we would use phonophoresis. That's the one. So that's where I wanted to make sure our language was consistent. Are we talking about phonophoresis versus ionto? Yep. I don't know off the top of my head which medications would be better with phonophoresis versus iontophoresis, or if there's an overlap. I can try to look that up. There are some contraindications. What contraindications are there for ultrasound that doesn't apply to? Is there any? Any contraindications we can think of that ultrasound has that electrical currents do not? So there's a safety element of moving it around. We also have the safety element of the buildup of ions. So we're just for bony prominences. So we want to stay away from thin skin and over bony prominence here, but we do have a little bit more leeway with ionto. So that's the other thing that I would say. Here's the other thing I will always say. I can stick a patch on the patient and tell them it will go away. I don't have to be there for this. So ultrasound, I've got to stand there for 5 to 15 minutes, depending on the area and the setting. Here I get to say, okay, press this button. I'll see you later. Come back in 10 to 40 minutes. It's, well, we'll look at exact dosing in a second. So anytime I don't have to be there, I'm definitely going to choose that. So most drugs, we want to deliver 40 milliamp minutes of the dosing. Can be as high as 80, but I don't see that often. So how do we calculate that? Well, I can turn these machines on, every single machine here. I can either deliver 2 milliamps, 3 milliamps, or 4 milliamps of a volt of power. So if I'm going to do 4 milliamps, it's only going to take me 10 minutes to get to 40 milliamp minutes. If I do 2 milliamp minutes, it's going to require 20 minutes. So that's just a simple math formula. If the patient can tolerate 4 milliamps, great, we're going to do 4. If they can only tolerate 2, okay, fine. Either wear for 20 minutes and take it off when it beeps, or you do something for 20 minutes. I'll go over here. You go away. Now, after we deliver the medication, after that 20 to 40 minutes is up, we're going to remove the charge. We're going to remove the electricity component to it, but we're going to leave the medication on because there can be some residual drug delivery. So leave it on for an extra little bit. A little vague on how long to leave it on for. I just say the next meal. Take it off at dinner, take it off at lunch. That's all I suggest. So number one thing we have to do is the additional safety thing we have to ask is, are you allergic to this medication? If there is, don't use it. It is not appropriate to assume that that question has been asked previously, because it's easy for me to make a mistake. And if you make the mistake next time, who actually is the one who delivered the medication? Yeah. So, yeah, make sure you probably don't have to ask it every single time. But the first time you work with a patient, you should be asking it. The first time you work with a patient, you should assume that they don't know, they haven't been asked this.
What if they have a reaction?
That's a great question. So the second time you work with someone, you're going to be doing a thorough skin screen and asking the patient how they responded if they had to use it away from where you are. Whenever the patient uses this for the first time, I do make them, I do it at the clinic with me able to monitor the skin after. But if for some reason we can't, we ask about reactions after, definitely, because that buildup of ions can happen. I've seen it once. I've used this, I wouldn't say a lot, but probably between 30 and 50 times in my career, I've used ionotophoresis, and I've seen it once. So I've seen that negative, not negative charge, but poor reaction once. So area of redness, just look like a mild burn. Yeah. Well, we need the same current to drive the medication through, and there is a barrier in the skin. That's why we're going to be changing some of the polarity with our electrical current. So I don't think these medications, I think it has to do with the size of the molecule, why they're not passive like these things. These things don't require additional current for it, just where it'll slowly go in. These medications are transepidermal and not transappendigeal. No. No. And with the drug allergy, they might not know they have an allergy to this medication. So what's our sensation for any of our electricity? Tingling sensation. This can potentially feel warm. It should not feel burning. It should not feel uncomfortable. It should not be painful or feel burning. If you are, we either need to change the electricity from 4 milliamps down to 3 or 2, or it's a negative reaction, not negative charge, but a reaction that we don't want. And this, for some reason, either the buildup of ions or a medication reaction. So does anybody know that they have one of these allergies? I don't know if I have one, right? So me, yeah. Yeah. Well, that's how we got rid of COVID, right? We all just drank chlorine and all right. Say that again. To take off the medication, yeah. I mean, it's already been delivered to the skin, so I would clean the skin, remove everything, clean the skin, call the doc. Is for you, talk to the PT, call the doc is the 3 steps you would take. All right, so we've got a bunch of different tools to use. We've got this brand here. This is Hybresis, great, pretty fun. So these are great pads because they're pretty foolproof. They've got a positive pad and a negative pad to it. You just apply this power unit to the electrode, to pads like that. You then apply your medication to either side that you need to, and you apply saline to the other side. Stick it on the patient, turn on, and down here you either choose 2, 3, or 4 milliamp minutes, and then depending on the medication, again, 40 is the goal. So it's either going to be between 10 and 20 minutes, 10, 15, 20 minutes, just depending on how much current they can tolerate. Again, that's more of a comfort thing. But that's pretty simple. Because this manufacturer, it's 1 inch apart, but this manufacturer decided they want to make this as user foolproof as possible. So the patient doesn't have to find 2 pads, but also it's connected to the 1 power supply. So it's just really this is really user friendly.
I just couldn't tell, like, if you hooked up or whatever.
Yeah, yep. Here's another one. Presser. So again, this is pretty simple, although we need 2 pads for it. And now we also need to make sure that we attach the appropriate electrode to the appropriate pad, which it can introduce user error. So this is probably something where we need to do it for the patient and not just say, oh, here you go, right? But the same process applies. Medication to 1 pad, saline to the other. You just have to make sure that the black negative charge is hooked up to the appropriate pad. So, and then slap it on, turn this on again, 2, 3, or 4 milliamp minutes. So that operation is pretty simple. I didn't get a chance to play with this one enough because I couldn't find the battery, but I'm sure it's pretty simple and the fundamentals are the same. These are pretty cool. There's a battery in here. If you hold this up to the light, you can see the battery. And this once we put the medication and saline, I think. I'll double check to see if it's a different thing we need for this. Yep, saline. Saline on one side, medication on the other. It activates the battery and then you just wear it. So that's pretty foolproof there too. So that's pretty easy.
Medication for-
Break the top. You soak the pad, make sure it's all nice and evenly medicated, and then that's it. It's a piece of cake. All right, so what I want to do now is I just want you to play with the few different versions, take a look at them, and then we'll move on to the next thing. Okay? All right, what other tissue repair stuff do we have? High volt galvanic is the next thing we're going to talk about. So with wound healing, again, I just want to make sure that we're all on the same page. I know we've talked about this a bunch of times in a few different classes. Inflammatory phase, tissue formation, and then remodeling phase. Inflammatory phase is the first 3 to 7 days. Localized blood flow will stop, followed by so vasoconstriction followed by vasodilation. We want to restrict blood at first because we don't want to lose a bunch of blood, right? We got to stop the bleeding, but then eventually it's going to quickly go into vasodilation and deliver more blood. Cell migration versus chemotaxi, like we talked about in patho. Arrival of different cell types, white blood cells and macrophages. Proliferative phase, now we're going to have more angiogenesis, generation of new blood vessels, wound contractions done by fibroblasts, production of extracellular matrix, and then the remodeling phase starting as early as day 3, as lasting as long as 2 years, where now the tissue is going to go back to its original makeup. So we can use electrical current to help with these phases. And just like with everything else in this class, I've really narrowed this down to hopefully the basic information that you need to work with, that if you are going to be the wounds PTA specialist, which again, if you decided to do that, then I think you would have a career, and I think you would be hired on the spot of any, especially skilled nursing facility. If you were to just walk in off the street to Grand Islander, which is a skilled nursing facility in Middletown, you just said, "Hey, I'm a PTA and I love treating wounds. Can I start working?" They'd say, "What do you want, tomorrow? Do you want to go next week? What do you want to do?" Like it would, and then you would say, "Yeah, but I want to make a lot of money." They'd say, "Well, if you're going to do the wounds, we'll pay you a lot of money." That's the trade-off. Oh yeah. In fact, I'll highlight that in a little bit exactly. There's one of my favorite thing from the textbook is in this section of the PowerPoint, so we'll go over that. You want to look at wound pictures? Sarah requested wound pictures. We'll Google wound pictures. So again, we are scratching the surface of the knowledge. I'm basically just trying to expose you to the world of electrical currents for tissue repair. That way that you can build your knowledge down the road should you need to. You can be part of the team if you are in a hospital, skilled nurse facility, outpatient with a patient, or home care with a patient that's having a lot of troubles. You could be the one to offer. I remember somewhere along the line being electrical currents for wounds. What did you think? Like, nothing else is working. What do you guys think about this? So that's what my goal is for you for this topic. So some of the indications: pressure wounds, venous insufficiency, arterial insufficiency wounds, diabetic ulcers. Kyle found the wound pictures. Is that what you just looked up? You guys don't see his face like I do. Contraindications, just like all of our other electrical current contraindications, pacemakers, carotid sinus, cancer, infection, active bleeding. Now we have metallic implants or metal ion from medications. So that's a new twist that we've got to consider. Pregnancy is now a contraindications for this stuff. Precautions, near cranium cervical area, history of epilepsy or seizure disorders. We should probably edit that, right? Strokes and sensation impairments and thin skin. So this gets to be really kind of, for me, it's abstract. I don't know if you guys will feel the same way. But we're going to be changing the electricity current within the skin. There is, when we have skin that is damaged, it changes, it interrupts the electrical, the normal electrical current of that skin. It is suggested that that is the trigger to start wound healing, and that we can influence wound healing by adding different either positive or negative charges to it. We'll look at some of the broad research for that in a little bit. So by delivering electrical currents, we are potentially mimicking the body's natural bioelectric currents, therefore jump-starting the wound healing process. Again, this isn't something where you'd say like, oh, we did get that paper cut we were referring to earlier. Here's an electrical current. We don't need it. This is for non-healing or really slowly healing wounds. Okay, we'll jumpstart the electrical current because that's what should be happening already. And for some reason it's not. Hopefully that'll jumpstart the healing process. Diabetic wounds is part of the indications. So, positive wound potentials are believed to be an indicator of healing. As the wound closes, the positive potential disappears. So the cells that are either positive or negative are going to be attracted to the opposite polarity. So macrophages are positively charged, so are neutrophils. So they're going to be attracted to which electrode if they're positively charged? The negative. So if we wanted to attract those, we would place the negative electrode either in or near the wound, and there we go. We're going to be attracting those things. If we want more fibroblasts are positively charged, so they're going to be attracted towards the negative pole. So that goes back to why I started with our recap of our wound repair. Because if we feel like as clinicians, and again, this isn't probably your decision-making process, but it is part of the thought process of the team. If we want to jumpstart the inflammatory phase, we want to attract those white blood cells and macrophages. All right, so that's going to tell me where to put my positive or negative electrodes. If I'm closer to the remodeling phase, well, I want more of those fibroblasts in the area. So now that I get to use that as the decision making for where I put my electrodes. Does that make sense? Just broadly speaking? Okay. That term is called galvotaxis. So when I refer to this as high volt galvanic is usually what I say. And that's because that's the mechanism that we're using or stimulating within the body. So we've got some different positive versus negative thought processes for us. We can use what phase they're in or what phase we want to stimulate, if that's part of our decision making. We have a couple of different protocols that's been researched to show that's been effective for partial thickness wounds, the first day being negatively charged and the next 7 days be positively charged. That seems to be a good use for it. For high voltage monophasic pulse current, that's high volt galvanic, though. If you look at our PowerPoints, it always, it says HVMPC. That's what we're referring to. It's the same thing I refer to as high volt galvanic, although I haven't been able to relearn this long one. So what that protocol for this is 3 days negative followed by 4 days positive. And you yield better results than using only negative or only positive or alternating negative and positive. So that's pretty interesting stuff, I guess. Nobody other than me thinks that's interesting. Everybody else is asleep. And I said, this is really interesting. We can have some antimicrobial effects to it. Various pathogens found in to infect wounds. So that's really only seen in animal studies and in vitro studies at this point. I wonder if eventually that'll be something that we can look more into. These wounds get, maybe we're not using these electrical currents as something to continue the healing process, but something to prevent it from being infected. Boy, if we could figure that out, I think we'd all be using electrical currents on all of the wounds just automatically. So I wonder if this keeps being shown in the research, if we're all going to need to dive into the learning process of using this more frequently, because that would be huge. So the electrical currents can also be used to debride dead tissue. This, we would use the positive electrode over the wound to attract negatively charged neutrophils that we had just talked about earlier, and macrophages. That would be nice. So does it work? Well, Medicaid and Medicare decided to that they will pay for electrical current for chronic wounds. And man, if we can convince them to pay, that's means that we've supplied them with enough evidence to say, like, okay, fine, we'll pay for this because it's working. So now some of the adverse effects, well, unpleasant buzzing or tingling that can happen. Although if our patients have diabetic ulcers, what do you guys think of the sensation? It's not great. So I think for this class of patients, we're probably not going to get too many complaints of that. That's nice. Stop complaining. How do you think Dan cares about his patients way more than I care about mine? Like when he says, I just sit and listen and care, and well, good, they're not going to complain. Let's do them. Yeah. Electrode surface area is going to be a consideration for us as well. We can be causing overheating or hyperthermic reaction could recur and could cause a thermal burn. So we do have to still be careful, especially with our patients with altered sensation. Now, here's my favorite quote of the textbook. Application of these currents requires more advanced and specialized training. So again, my goal is just to give you some knowledge that this stuff we can use this. There are different there are different classes, training, certifications that we can use to become wounds experts. I would never, in my home care setting, talk to a nurse with a patient with a wound it's not healing well. I would never say, hey, I know we can use these electrodes. Even though I know it can happen, I don't have the level of training and expertise to actually apply it to a patient. I would not feel comfortable doing that. But it's an avenue that we could go down. There was a PT. Tony, did you ever meet Moose?
What was is he a PT?
Moose is a PT that only did wounds. He didn't do any traditional physical therapy. He only treated wounds. I mean, with a name like Moose, Moose was gigantic. He was like 6'7", but all he did all he did was wounds. He didn't do sit to stand exercises or stretch it. Like all he did was come in and treat wounds, both with debriding techniques, with tweezers, scalpels, things like that. And he used a ton of electrical current for it. Pretty brilliant guy, really sought after. And again, I mean, hey, we got a trouble wound, call Moose. Like he was an amazing guy that I got to meet once. And I mean, there was a short time where everybody knew who Moose was because he was the PT that did wounds, and he did amazing work by using some of this stuff. So anyway, we have two different techniques I want to talk about that you should have in the back of your mind: a direct technique and a peri-wound technique. So direct technique, we want to place the electrode directly into the wound. Active electrode would be in place, which would be the negative electrode in this case, would be placed in the wound bed. Dispersive electrode, 15 to 20 centimeters distal to the wound. And then we have a peri-wound technique, which the electrodes are around the intact skin around the wound. So here's the direct technique. We'd want to moisten this gauze with saline and then place the electrode on the gauze. There's a few different types of electrodes. This is an aluminum foil electrode type, so that's pretty fun. And then there's a positive electrode, 15 to 20 centimeters, not shown here, away from that. Our parameters between 75 and 150 volts, pulse frequency 100 pulses per second, treatment 60 minutes a day, 7 days a week. That's a lot of treatment, right? Has any other treatment been that long that we've had? So TENS for opiate liberation, as long as the electrodes are fine and not causing a burn. That's the only other thing that was close to this. So pretty amazing. But then again, if we're thinking about non-healing wounds, that starts to make sense why we need that frequent of a treatment. Yeah. Yep. What's that? Yep. Likely more inpatient. Moose was home care therapist. So I don't know what he would do with the 7 days a week or not. But I also think that he could train a PTA who works on the weekends theoretically, or, if he told me what to do, I would say, okay, Moose, I'll press that button. Okay, that's how you do it. Like he could train me onto an application, not necessarily the thought decision-making side, but just the quick application. Check for this, make sure it's not that, press this button. Yeah, we could do that. Clarity depends on the clinical needs of the wound. 3 days positive, 3 days negative cycles, constant negative. It just depends on the wound itself. I think more and more research will guide us more and more on that. Again, I think that's something that if you decide to be the wound therapist, I think Allie's going to be the wound therapist. Don't you think so? Is that where you're going to be? Yeah. So we could use high volt for edema. This is something that I think that we should be aware of. And I've used high volt galvanic for edema. I haven't used it for wound care itself, but I have used it for edema. So edema has a negative charge to it. So we would want to place the negative charge over the area of edema and the positive charge proximally, driving the edema towards the positive electrode. We would have a continuous duty cycle for that, 80 to 120 pulses per second. Here's a picture of the peri-wound technique. I probably should have rearranged the order of these slides. So that's where the electrodes, this gauze is just trying to simulate a wound. Anybody want to give themselves a wound to practice this stuff? All right, so here's our recap for this. Our wound parameters and also our edema ones. The edema ones I definitely want us to practice with and feel, because all of our patients at some point are going to have edema problem, right? Just a grade 2 ankle sprain. Maybe that guy that Dan was talking about that the podiatrist told him to put in the walking boot, that person comes in, really tough ankle sprain with lots of swelling, and they're an athlete with playoffs coming up in 2 weeks, and we want to be ultra aggressive in it. That's the type of thing that I would be apt to use the galvanic to drive away the swelling as fast as possible. So I do want us to practice that. It is important for us to know the broad application of it for wound technique, especially peri-wound. Like, we can use it for peri-wound or direct wounds as well. So what I want to do is practice definitely edema of lateral ankle, and you can practice simulation of our wound parameters. Now, when we use these machines, the tall ones here, those don't have 5 volt, right?
Yes.
They do? Oh, all right. I haven't played around with those yet. So when we plug in our wires, what did you do with this, Mary? So electrotherapy, that's where we've been living for a while. And then we just get to pick high volts, left column all the way down. The active electrode is the red tip. We can change if it's positive or negative with the settings of the machine. We would edit and change that to positive or negative if we want. Okay. So right now the polarity is set to negative. So if I was doing that edema, high volt for edema, perfect. I would place the red tip with the pads on it, not just, it's set to negative. Perfect. Apply it. This would be the positive one. We'd apply that to the other side. If we were going to do wound stuff, again, depending on what we want out of our jump starting of this wound healing process, I might need to change this to positive or negative. But again, the active electrode is the red tip. Okay. All right, let's go around and let's go ahead and play with that. I want you definitely for edema, and then you can start messing around with for wound care stuff as well. Okay.